specific exclusion criteria?
So I think concerns about safety and the increased risk of diabetic ketoacidosis in the type 1 population, we should say that there's an ongoing trial of empagliflozin, kidney, that I believe is recruiting patients with type 1 diabetes. So we may have additional data in this population soon. And there have, of course, been other trials of these drugs in patient populations with type 1 diabetes.
Another question for you, those without type 2 diabetes, what proportion had pre-diabetes? Was the A1C measured?
Yeah, it was indeed measured. It was measured at the screening visit and at the randomization visit. If we disagreed with the investigator's call on whether the patient was diabetic or not, based on WHO criteria, so if both those baseline HbA1cs were above the WHO threshold, then we classified the patient as having diabetes and we analyzed them as if they had diabetes. Regarding the rest of the patients who didn't have type 2 diabetes at entry, based on WHO criteria, did they have glucose intolerance, mild diabetes? We haven't looked into that in great detail yet, but hope to publish on that at a later stage, because I think there've been similar criticisms of the dapa HF study in terms of, are we just dealing with a group of patients who actually have mild diabetes? We don't think so, but we'll look at those data in more detail.
And a question for you about, I think you mentioned that 20% of patients had a biopsy. Have you looked at those who had biopsy-proven GNs to see the efficacy of the drug?
No, that's a great question. So the biopsy data are not terribly detailed. What we asked the investigators in the case report form is whether or not the diagnosis they made, so the call that they made on the etiology of the kidney disease, was supported by biopsy evidence. But we don't have the details of those biopsies. We don't have the biopsy report. So it's difficult to dig into that in any more detail. I think we're fairly confident that those patients with IgA nephropathy had IgA nephropathy, for example, but we haven't got detail on all the other subgroups.
Questions about the impact on proteinuria in the subgroup that had glomerular nephritis?
So all of these patients, remember, had proteinuria. Albuminuria was an inclusion criterion for the study. So we're dealing with a group of patients with eGFRs between 25 and 75, ACRs between 200 and 5,000. And so we're only dealing here with proteinuric patients. What happened to proteinuria in those subgroups, we haven't presented those data yet, but we will be looking into changes in albuminuria in a future analysis.
Thank you. And will you be subgrouping by low levels of albuminuria versus higher levels at baseline?
Well, yeah, I mean, we in the primary publication in the New England Journal, we have actually stratified patients by the entry UACR lower or higher than 1,000 milligram per gram. And we saw no heterogeneity of effect on the primary outcome in those who went into the trial with the lower versus the higher levels of albuminuria. So a consistent effect across at least those two subgroups of albuminuria.
Terrific. And can you comment about the effect on blood pressure and whether that was a factor with the groups that, since the non-diabetic CKD, the glomerular nephritis group had a lower blood pressure at baseline? Can you comment about that?
Yeah, I mean, they had those with glomerulonephritis had lower blood pressures at baseline. The blood pressures were actually balanced between the two groups, the DAPA versus placebo. Of course, that was on entry, that was the pre-treatment. We haven't actually analyzed blood pressure data during the trial in any detail as yet, but we will be looking at blood pressure. And obviously there's an interest in whether some of these benefits are mediated by blood pressure reductions. And we know that in type 2 diabetic populations, these drugs lower blood pressure. So it is possible that some of the benefits are linked to blood pressure reduction.
Terrific. And within the non-diabetic kidney disease group, there was not a significant impact, I believe, on cardiovascular mortality and heart failure. Was that just driven by the low event rate?
So I think we should remember that this trial was stopped early by the Data Safety Monitoring Board. We actually only accrued 2/3 of the events that we plan to accrue, and only 2/3 of the events that our power calculations were based on. So we lacked power. And I think that shows when we look at numbers of events in some of those subgroups. And yes, you know, there is heterogeneity and variability for that cardiovascular outcome. Agree with that. It's not statistically different according to the P for heterogeneity in that analysis. And if you look at the numbers of events, particularly in the non-diabetic population, then there weren't that many events. But remember that all-cause mortality was reduced in that non-diabetic patient population. So we're doing something right here. We may just not be particularly good at picking up, you know, causes of death in these patients. And the cardiovascular events, that composite was driven by heart failure more so than cardiovascular death.
Maybe one last question for you to comment about serious adverse events and those that didn't require, what were the serious adverse events that didn't require discontinuation?
The serious adverse events that didn't require, I mean, there's a whole variety of issues here, as you would expect in a group of patients with advancing chronic kidney disease and diabetes. I mean, I can tell you what we were looking out for and what we didn't see, and that was amputations. We didn't see an imbalance in amputation rates, and we didn't see an imbalance in dehydration, so in overdiuresis leading to issues related to dehydration. So we didn't. The answer is a variety of different events were captured in those serious adverse events. We didn't see any imbalances, particularly in those that we were looking out for quite carefully.
Thank you very much, Dr. Wheeler. That ends our Q&A portion of